Good afternoon, everyone. Welcome to today's national webinar and congressional briefing, Taking Heed of Alzheimer's Disease, Recognizing and Responding to a Coming Crisis. My name is Catherine Schubert, and I'm President and CEO of the Society for Women's Health Research. SWHR is more than 30 years old, and we are a national nonprofit organization dedicated to promoting research on biological sex differences in disease and improving women's health through science, policy, and education. Before we move into today's program, I want to share just a few housekeeping items. First, please note that today's web event is being recorded and it will be posted online. We'll be sending out the recording and any additional resources that are mentioned in a follow-up email to all registrants. All participants have been muted and cameras are turned off. This is intentional to highlight today's speakers. So to ask a question to the panelists, please use the Zoom Q&A function. You could use the chat function as an alternative. Just know that with multiple functions, the place we're looking first is the Q&A function. We will ask questions at the end of the event following all panelists' presentations. And if you need technical assistance, that you should write into the chat function. Just note that we'll have limited technical assistance available while the webinar is running. So we are thrilled to host today's event alongside tremendous partners who helped pull this briefing together. And I'd like to extend our sincere thanks to the co-hosts of today's event, Us Against Alzheimer's, and the National Alliance for Caregiving. SWHR would also like to thank Isa and Lily for their support of this program. And we are joined today by an esteemed panel of experts who will explain Alzheimer's disease's disproportionate impact on women, both as patients and as caregivers. They'll provide insight into why Alzheimer's disease must remain at the forefront of federal research efforts and discuss how policy changes could affect outcomes. Dr. Fawn Cothran is the Hunt Research Director at the National Alliance for Caregiving. She is a nurse scientist and a board-certified gerontological clinical nurse specialist with more than 15 years of experience in dementia family caregiving and related activities. Niles Godis is the Chief Government Relations and Policy Officer at Us Against Alzheimer's. Niles has nearly 30 years of experience shaping public policy. He served as Democratic Staff Director of the U.S. Congress Joint Economic Committee and as Chief of Staff for Senator Dorgan of North Dakota. Most recently, he served as Senior Vice President of Congressional Affairs for Leading Age. Dr. Jill Goldstein is a clinical neuroscientist who currently serves as professor of psychiatry and medicine at Harvard Medical School and the founder and executive director of the Innovation Center on Sex Differences in Medicine at Massachusetts General Hospital. She's also the Helen T. Morshner Endowed Massachusetts General Hospital Research Institute Chair in Women's Health. And finally, last but certainly not least, today's moderator, Brooks Kenny, serves as the Vice President of Consumer Engagement and Partnerships at Us Against Alzheimer's. In this role, she leads consumer-facing platforms and partnerships that engage people to advance the organization's mission. She also directs the Women's Leadership Council and is a nationally recognized subject matter expert in caregiving and women's brain health. And so with that, I will turn it over to you, Brooks. Thank you so much.
Great. Thank you so much for that kind introduction, and thank you all for joining us today. I'm going to go ahead and share my slides and just provide a little bit of a level set or overview of where we are with women and Alzheimer's disease. And then I'll be moving into the panel presentations. We know that women pay a high price in Alzheimer's disease, and we know that the knowledge and awareness across our country still remains fairly low. Even looking at it from an economic perspective, folks are often surprised when they hear about the economic burden that Alzheimer's disease has on our society and on women in particular. This is a chronic long-term disease. Many people live with Alzheimer's disease for 10 or 20 years, and making that economic burden and the out-of-pocket costs for caregivers, which we'll hear more about, pretty tremendous and a very significant burden for the audiences that we're talking about today. We also know that women are disproportionately impacted by this disease. And what is surprising to me, continues to be surprising, is that when we share these statistics, people are unaware. They're unaware that women in their 60s are twice as likely to develop Alzheimer's disease than breast cancer. Many are surprised to hear that women bear 80% of society's total cost of Alzheimer's, or that we make up 2/3 of the American population living with the disease. We also make up 2/3 of caregivers. So it's a pretty high price for us to pay. When Us Against Alzheimer's was founded back in 2010, we were founded with a vision around supporting those communities that are most impacted by the disease. Women, with particular focus around women of color. We know that women are bearing this great burden, and we know they need our support, and they need policies to help them manage these challenges. So let's just review some of the statistics and facts. We know that Alzheimer's is the 5th leading cause of death among women in the US. We know that it's not just an older women's issue, but women in their 50s can have the disease. And we know, based on lots of reports, a recent one that was just put out by AARP, that Alzheimer's remains highly stigmatized. And women in particular over 50, they say that Alzheimer's disease is their top fear. So we know that there's a long way to go in terms of understanding Alzheimer's disease and how we address both detection and diagnosis. It is really a threat to a woman's overall health and well-being. We know from the data that many women are forced to make changes in their career or slow down their career because of Alzheimer's disease, whether they have it themselves or they become a caregiver for a loved one. We know women are more likely to care for family members, and that family member might be a spouse, it might be a mother, it might be a mother-in-law or a father-in-law or an aunt. We know that women are largely raising their hands to take on the caregiving duties when someone has a diagnosis of Alzheimer's disease. But here's the tricky part. Alzheimer's disease is often diagnosed late. In fact, more than half of cases are never diagnosed. And when we are diagnosing Alzheimer's disease, we're diagnosing it often when the treatments that we're hoping are going to be coming to the market are not as relevant to that patient. It's often getting diagnosed during a crisis or something chaotic. Maybe it's a fall, maybe it's somebody getting lost. And it really puts the family into a tailspin. When we think about early detection and diagnosis of Alzheimer's disease, we should not be thinking about the moderate or later stages. Let's make it a little more simple. Let's think about cancer. We know as a community, as a society, that an early diagnosis of cancer is much better than a late one, right? Well, what are the reasons? Because you're going to have access to state-of-the-art treatment, perhaps through clinical trials. You have more time to plan and make your financial and your care plan, more time to build your support group with your family, more time to identify local resources that might support you. All of these same benefits are true when it comes to Alzheimer's disease, yet we really haven't put it at the top of our list. And as we think about how to change that narrative here at Us Against Alzheimer's, we are very much focused on having a conversation around brain health. We want women in particular, who we believe are the chief medical officers of their families, right? They're the ones starting those conversations around the kitchen table. They're the ones often managing family members' medical appointments. I know it's true for me. I do it for my 2 kids as well as my husband and myself. And that's fine, but we need to actually empower women to take control of their brain health, to start seeing their brains as vital organs, to reduce that stigma and try to get into a place where we're thinking about our brains in the same way we think about our hearts and our overall health and wellness. So I've shared a lot of points today that could imply doom and gloom, but I want to share something that we've done specifically at Us Against Alzheimer's in order to bring about change with women in particular. We did some market research, and what we learned was that women weren't really talking about their brain health, but they wanted to. In fact, 68% said they were interested in learning more about how to measure and track their brain health. They want to be able to talk to their provider if they knew how, but many don't know how to raise this topic. They said the health and performance of their brain was important to them. And half of them are dealing with dementia. This, again, was a survey that we did a few years ago with women between the ages of 35 and 64. Now, if we believe that women are the chief medical officers of the family, and if we believe that Alzheimer's is stigmatized, but a conversation about brain health might lead us to more empowered communities, people that are talking more about this topic, we think we can really move the needle. And so that's the place that we start from at Us Against Alzheimer's. We recognize it's complex. The challenges are vast, but we try to bring many groups together, and we're doing it today as an example, to improve brain health and promote earlier detection and diagnosis, to champion health equity. And we really are talking about women, and we're talking about women of color in particular, to ensure that people have access to the information that they need, and they have access to easier ways to get into those conversations around their memory. We need to continue to advocate for research spending, which my colleague Niles will share more with you about. And we really need to focus on changes that matter most to people living with the disease. If you think about it, when you look out and hear stories around patients and patient advocates in other disease areas, we often hear from the people living with the disease. You know, it's not uncommon to hear from a breast cancer survivor or someone going through a treatment of cancer or heart disease when women in February are wearing red. And we are really working hard at Us Against Alzheimer's through our collaborations to empower women to start sharing their stories, whether they're caregiving, whether they're living with the disease. We need to put those faces front and center. And we believe that that is also a key towards changing the narrative around Alzheimer's disease and supporting more women across the country. And so with that, I want to actually turn it over to my colleague, Dr. Jill Goldstein, who Jill has been part of this women's work since the day I met her. I think 10 years ago, Jill, I think it's been since we started working together. You really have been such a trailblazer in this work and such an advocate and such an expert. And I would love if you could share your slides with the group, and if you could give us a level set around the science. You know, what do we know about the biological sex and gender differences in Alzheimer's disease? Where do we still have a lot of gaps in research? And I think key to this is also, what can the women that are listening learn and take away from what we know right now in the science? So thank you so much for being with us, and I'll turn it over to you, Dr. Goldstein.
Okay, can you see my slides?
We can.
All right, well, I will just jump right into it. First of all, thank you so much for the introduction and for having me here today. I'm really honored to be part of this panel. My job today, as Brooks just told you, is to tell you something about the science of sex differences in Alzheimer's disease. And I'm going to talk about the biology of sex as opposed to, or in contrast to, gender differences. And my other two colleagues will talk about gender. But sex and gender have different effects, although they interact with each other. But I'm going to be focusing on the biology of sex and how we can think about that in terms of our risks and resilience to Alzheimer's disease. So what do we know now? What do we know now? Okay, did you know that 18% of the US population is over 60 years of age, and there's a predominance of women to men? These projections will reach 25 to 30% by 2050. And over 1 of every 9 individuals over the age of 65 has Alzheimer's disease. Over 6 million Alzheimer's patients in the US alone, and there should be 20 million by 2030. These costs, they're over $200 billion a year, and left untreated, they'll reach over $1 trillion by 2050. And women, as Brooks let us know, make up 2/3 of the Alzheimer's disease population. And we now know it's not only because women live longer. So maintaining intact memory function is one of the public health challenges of our time. Now, sex differences in frequencies of dementias really cross dementia. And so we first talked about Alzheimer's disease, but there's also vascular dementia, which looks like overall the frequency is similar, but in fact, it occurs at different ages. There's different prognosis, there's different severities in men and women. So overall, there is a disproportional number of women that are affected by dementia, and particularly Alzheimer's disease. We know it's not only because women live longer, and in order to develop more efficacious treatments and strategies for prevention, we need to understand the impact of sex. Now, there are sex differences in the brain. They are pervasive, although they're small. So there are differences in the size of regions, in the wiring of the brain, even though the functions that we perform are essentially the same. And although these differences are small, we need to understand how they develop, and they begin in fetal development, how they are retained across their lifespan, and how they impact function in order to tell us really significant things about sex differences, not only in Alzheimer's disease, but across multiple chronic diseases that we know. And some of the largest sex differences in volume and functioning in the brain are in the memory circuitry. And those differences in memory circuitry have implications for differences in memory function. In this case, we're looking at verbal memory or memory for words, which is a really key problem in Alzheimer's disease. So here, not sure you can see my pointer. If not, I'll just talk you through this. You can see on the y-axis, the number of memory trials. At the bottom, you see ages 30 to 70. On the left is the men, on the right is the women. And if you look across these ages from 30 to over 70, women actually have an advantage in verbal memory function. And in fact, sex differences in verbal memory function emerge just post-puberty, are retained across our lifespan, and then attenuate with postmenopause, attenuate with ovarian decline. But in fact, in the healthy brain, we still retain a slight advantage. So why would it be then that women have a higher frequency of Alzheimer's disease, since verbal memory is one of the key symptoms that declines in Alzheimer's disease? Well, there are a number of potential causes for that. And I'm going to talk you through a few examples. I don't have that much time today, but I just want to give you a flavor about what we're thinking about in science now to try to understand the fact that it's not only about the fact that women live longer, but there are other things going on that we need to understand. And they have to do with hormonal effects, which I'll talk about in a moment, genetic effects, our immune system, our vascular system, and our metabolic system. That is how the brain and the body produce energy, like insulin from insulin, glucose pathways. And all of these things differ by sex. Now, let's just start with hormones, gonadal hormones in this case. Sex differences in brain aging is affected by our gonadal hormones. So men and women undergo different aging processes in midlife. Men and women obviously both go through chronologic aging, but women also go through a period of what we call reproductive aging. So here you can see on the x-axis birth up until about age 85. And in the red line here, you can see a steep rise over puberty in women for estradiol, which is the primary form of estrogen that works in the brain. And for men, there's a rise in testosterone. But then you can see around age 50 and older, there's a depletion of estradiol in women, or there's an ovarian decline. And there's only a gradual decline in testosterone in men. And this depletion of hormones has really significant effects on our memory function and memory circuitry. Why is that? Well, it's in part because there are shared brain regions that regulate both the release of these gonadal hormones, as well as our memory performance. Areas like the hippocampus, the hypothalamus, they're really key in regulating the release of estradiol, as I said, the primary form of estrogen that works in the brain, from the ovaries in women, and testosterone from the testes in men. And as I said, the estradiol has a really important role in increasing activity in memory circuitry regions and helping our memory function. And the loss of that can impact memory circuitry function. And so it produces some cause for why we see some of these sex differences in how our brain ages. How about genes and AD, Alzheimer's disease pathology, which shape the risk and the course? Well, the primary genetic risk for Alzheimer's disease is the apolipoprotein E, or ApoE, and its E4 allele. And it turns out that given the same genetic risk, that same E4 allele, postmenopausal women have more severe AD pathology than men. And AD pathology, what I refer to is the neuritic plaques, which we measure by amyloid in the brain, and neurofibrillary tangles, which again we measure by tau. And estradiol has been found to reduce the accumulation of amyloid, reduce the accumulation of tau. And so the loss of estradiol can have implications for the accumulation of AD pathology, particularly in the face of high-risk genes. Our immune system differs by sex, and this starts in fetal development, and it's true for our innate immunity, that is sort of our first line of defense, and our adaptive immunity, which has to do with how we respond to foreign invaders, like COVID, for example. And men have a more vulnerable immune system than women. It happens early in development, in fetal development, and that vulnerability is retained across the lifespan, whereas women have a more robust immune system. And in fact, that may help us understand some of the sex differences we saw with men having higher death rates from COVID. For example, men have a lower response to vaccines than women, than premenopausal women do. And that helped us explain some of the higher death rates and more severe illness in men. So our immune systems differ, and they differ not only in how they develop, but how they age over time. Microglia, for example, is an immune cell in the brain that's really the kind of, we call it the garbage collector. It collects dying nerve cells in the brain. And while we're sleeping, that microglia starts to reduce the accumulation of amyloid in the brain. And sex differences we've seen specifically in those immune cells in both their development and how the male and female brain age over time in relation to immune. So immunity is one of these really important causes that there's been a lot of discussion around recently. How about our vascular system? Well, there are major differences, sex differences in our vascular system and our autonomic response, and vascular dysfunction has been found to be a risk factor for Alzheimer's disease. Cardiovascular disease, for example, is a small vessel disease, microvessel disease in women, and we've discovered it's more of a large vessel disease, which is more of the traditional way of thinking about it in men. And with that discovery, we have found different treatments, different prognoses, different course for cardiovascular disease, which is an independent risk factor for Alzheimer's disease. And even how our brain regulates cardiac function, our autonomic function. When we exercise or when we're under stress, our heart rate goes up. We can't leave our heart rate up like that. Otherwise, it will have adverse effects on multiple tissues. So we need our parasympathetic regulation of the heart to slow it down. And that parasympathetic regulation of the heart differs by men and women, and autonomic dysfunction is not only a risk factor for cardiovascular disease, but in fact, it's also associated with Alzheimer's disease. And finally, aging impacts how the body and the brain produce energy in order to function. Metabolism and metabolic dysfunction is also a risk for Alzheimer's disease. There's brain metabolism. Here you can see on the left a series of brains that are really showing us glucose metabolism in the brain. Glucose is the primary fuel that nerve cells use in order to function. And estradiol, with the loss of estradiol, we lose glucose metabolism. So the brain, after a menopause, needs to look for other sources of fuel. And sometimes the brain can do that when women have a healthy aging process, and sometimes the brain cannot. And we need to understand what is the difference between those two. And then our gut. of course, we've heard a lot about how what we eat affects our brain. Well, there's a really important gut-brain axis, and gut metabolism can impact the brain, and that also differs by sex. And these 5 causal pathways are associated with sex differences in diseases that are also associated with the risk for Alzheimer's disease, cardiovascular disease, diabetes, depression and anxiety disorders, which are associated with hormone and immune pathways. And these 3 major diseases, cardiovascular disease, diabetes, depression, are independent risk factors of Alzheimer's disease. And they show sex differences which actually occur prior to the onset of Alzheimer's disease. And we believe and have been studying how the sex differences in these chronic diseases are related or shared with Alzheimer's disease. Now, why is that good news for Alzheimer's disease? Well, Alzheimer's disease, we know, starts 15 to 20 years prior to the onset of symptoms. And cardiovascular disease, diabetes, depression, these diseases primarily occur prior to Alzheimer's disease. So if there are shared causes that we can target prior to the onset of AD symptoms, that provides some optimistic approaches and novel approaches for targeting how to remain resilient and how to potentially prevent Alzheimer's disease. 95% of cardiovascular disease is modifiable. So we can be working on this 15 to 20 years prior to Alzheimer's disease. And we know there are sex differences in these diseases, so we can do it in a smart way, applying a sex difference lens. Now, why is that important, again, to think about understanding the risk and resilience to Alzheimer's disease? As I said, there is a trajectory to memory decline. And for Alzheimer's disease, it begins 15 to 20 years earlier. Our treatments used to focus on clinical dementia. And we found when you target late in the illness, or even at the onset of symptoms, you've kind of missed the boat. So then the field has been focusing on mild cognitive impairment. Well, so far, we haven't found a completely effective treatment for that as well. So now the field is really focusing on the preclinical period. How can we identify these high-risk populations? Who is it within these high-risk populations that are going to onset later on in life with Alzheimer's disease, and who it is that can maintain resilience? Well, this age group is 45 to 70 years old. And as I just told you, that's a critical period of reproductive aging in men and women in which sex differences in aging emerge. So we can use this information earlier to try to, again, create more efficacious treatments to target the risk and potentially prevent Alzheimer's disease in a sex-dependent way. How can we maintain intact memory function now? Well, the 3 pillars are effortful cognitive activity, effortful physical activity, and social contact. Activity to the brain is music. It's really important. If you don't stimulate a neuron, it will die, a nerve cell, a neuron. And we now know this is being broken down into how physical activity, cognitive activity, even social contact, people looking at this at the cellular level. And so we not only know that these activities differ by gender, right? But we also know that they differ at the cellular level by sex. And so understanding these differences, again, can help us maintain resilience, as Brooke says, maintain brain health. So now I'm going to just end with a call to action, because we need to capitalize on this novel opportunity around applying a sex difference lens. We need sustained commitment to understanding the causes of these sex differences. We know a lot now, but we need to know more. And those differences cross disorders, disorders that occur prior to the onset of disease that we could be targeting early using sex-selective diagnostic tools and therapies. We need to train the next generation to create a novel workforce that thinks about sex and gender effects. We need sustained financial support for research, for clinical care and services. Delaying costs, economic costs, by even 5 years would decrease Medicare costs by 50%. I'd say that's a really good return on investment. And adoption of this lifespan approach my lab is looking at the fetal antecedents, the early developmental antecedents of how our brain ages, because there are things about brain aging that are also about development, and using a sex difference lens to develop these therapies prior to illness onset is key. And we need public policies promoting health informed by sex and gender, which Niles will talk about in a moment, because creating that, doing so will create a market for the use of these sex-selective therapies. So precision medicine, we've heard about precision personalized medicine. What could be more personal than one's sex? Every cell has a sex. Every cell has a sex chromosome complement, XX, XY, or some variation on that theme. And so in order to develop more efficacious, more precision medicine therapies for the brain and for Alzheimer's disease risk and resilience, what we say at the Innovation Center on Sex Differences in Medicine is that when it comes to health, sex really does matter. Thank you.
Thank you so much, Dr. Goldstein. As often as I've heard you speak, I always learn something new, and I'm just so inspired, as I'm sure our participants are, by how you break it down. You break down the science, and reviewing those 5 causal pathways was super helpful. I have a couple questions about stress that I think I'll ask you during the Q&A.
Sure.
I also really loved the way you framed this idea that it's good news and there's something to be optimistic about around the fact that we are looking at depression, diabetes, and cardiovascular disease. Because those happen earlier, it opens up that window for these important conversations, right, around our brain health. And I just think the way you framed that is super important, and there's a lot to be optimistic about. So thank you, as always, for your expertise.
Thank you.
So we're next going to hear from Dr. Catherine with the National Alliance for Caregiving. And, you know, we've often heard if you've met one person living with Alzheimer's disease, you've met one person. And I think the same is probably true among caregivers for people living with Alzheimer's disease. I know I was a caregiver to my mother-in-law, working hand in hand with my husband when she was in her journey. And it is a long journey, and would love to have you share your perspective. What is a typical caregiver? Although typical is a hard word, because I know everybody's experience is very unique. But what are the impacts on women in particular? What are some of the challenges that are unique to women? And what does it really look like to be a caregiver for someone with AD? You know, it's interesting when you think about caring for loved ones with other chronic conditions where they are of sound mind. It's a different experience than when we think about Alzheimer's disease. And you all have really done such trailblazing work in research to help the field, to help all of us make the case for new policy and supports for families living with Alzheimer's disease. So welcome to the discussion, and look forward to hearing your comments today.
Thank you so much for that. And thank you to our partners, and again, to the Society for Women's Health Research for this invitation. I'm very grateful for this opportunity to not only discuss Alzheimer's disease in women, but also the caregiving perspective more specifically. Next slide, please. So you've kind of given an illusion of what I'll talk about today. So just briefly, I'll go over just Alzheimer's disease caregivers in general, their role. I'll talk about some challenges and benefits to caregiving. I'll specifically go into the impact on women, and then I'll conclude with a call to action. Next slide, please. So before I get started, although I'm focusing today on Alzheimer's disease caregiving, I do want to say that the work of the National Alliance for Caregiving does support a society that values, supports, and empowers family caregivers across condition and lifespan to thrive at home, work, and life. So to put us all on the same page, I'm just going to use the RAISE report to Congress's definition of family caregiver. And it's a family member or other individual who has a significant relationship with and who provides a broad range of assistance to an individual with a chronic or other health condition, disability, or functional limitation. Next slide, please. There are over 11 million unpaid family caregivers for a person living with Alzheimer's disease in the United States. As you've already heard, the majority of caregivers are women, and they provide roughly 16 billion hours of care, valued at $272 billion. They are literally upholding our society. Alzheimer's disease caregivers also provide an average of 27 hours per week, which is the equivalent of a part-time job. And I do want to add that with COVID and the numerous restrictions and lost services, these numbers almost certainly increased. Next slide, please. I do want to highlight Alzheimer's disease and caregivers in communities of color caregivers. And so one of the first things is that caregivers are generally younger. They are also primarily women, although those proportions may be higher due to differences in their self-identification as caregivers. Sometimes there's some discrepancy with using that term. Care partner or other terms may be more common. They are adult children caring for parents, which includes millennial caregivers. And they're providing more hours of care and have also been providing care longer, which is often due to the later diagnoses, as was talked about a little earlier, which is common in communities of color. They're also more likely to live with their care recipients or the persons that they're providing care for, and they also may manage more dementia-related behaviors. Next slide, please. So caregivers have a complex role to maintain the safety of the person that they're caring for, which will include, but is definitely not limited to, assisting with activities of daily living, such as bathing, feeding, or dressing, as well as instrumental activities of daily living, such as transportation, grocery shopping, or paying bills. Caregivers also manage medications. They provide emotional support. They perform care management and advocacy to ensure the needs of their family member are met. They set and attend appointments, and as Brooke shared from her own personal experience, she's managing appointments on both ends for children and self. But caregivers of Alzheimer's disease persons are also doing this. And in addition, they're also managing various behaviors, which can range from wandering or agitation or vocalizations or repeating phrases. And again, this is about keeping those individuals safe. And so caregivers, that is their priority, is to keep persons safe. But there are so many aspects to this role. Next slide, please. Now, some of the various challenges of caregiving include stress, invisibility, reduced work, physical and mental health outcomes, as well as nutrition and immune function changes, and finally, isolation. Now, I do want to clarify that when I speak about the challenge of invisibility, caregivers and all that they do are often not seen or recognized as the valuable team members and experts that they are, and we hope to change that. Next slide, please. Now, despite the challenges, because this is not all doom and gloom, I also want to acknowledge the positive benefits of Alzheimer's disease caregiving, which includes sense of purpose, satisfaction, opportunity to resolve conflict, strengthening relationships, and a way of giving back. Next slide, please. Now, just to talk about the impact on women, so the Alzheimer's disease caregiving impact is disproportionate, not only because they make up the majority, which as you heard is over 2/3, but with women more commonly impacted with Alzheimer's disease, and they are providing the bulk of care, which generally will fall on daughters, there is a double jeopardy, which may be exacerbated by socialization and or gendered norms. Next slide, please. So when intersecting identities are reflected, caregiving challenges will intensify for women of color based on cultural values or expectations, as well as social, economic, and environmental contexts. In fact, we actually don't know, they're not well understood in diverse populations and research because there's been a tendency for us to combine racial and ethnic communities together when actually there's considerable difference within those groups. But the good news is that there are several Alzheimer's disease caregiver researchers who are seeking to understand and intervene in communities of color. Next slide, please. So let's go in a little deeper into some of the challenges for women. So women balance other demands. And so working, often caregivers are still working. They may need to leave their jobs at some point, but oftentimes they are beginning this role or in the middle of this role while working. They are also caring for more than one individual, or they're called sandwich caregivers, which means that they may be caring for a child and or an older adult. And they will also repeat the role. So then it becomes this balance again, or this practice again of trying to do it all or to balance all of these other demands. There's also economic implications in terms of the challenges for women specifically. There is the feminization of poverty, or the overrepresentation of women who are in poverty, which is reinforced by well-known wealth gaps in communities of color and the persistence of gender wage gaps. Women and marginalized groups are overrepresented in hourly wage positions, or they're underpaid in direct care positions, which often don't have job flexibility or benefits. And so that has an impact. And then also the early workforce separation. So as I mentioned before, women may be working, but when they have to separate because they don't have the flexibility, they don't have leave, they're not able to take time off. And so if they have to leave the workforce, that exacerbates financial strain and impacts their short and long-term financial security. And then finally, caregiving challenges may actually worsen health conditions. The top three leading causes of death in women are heart disease, cancer, and stroke. And so we already know that there are well-established health disparities in communities of color. So women who are in these communities are also impacted. And so caregiving on top may actually worsen health conditions. Next slide, please. So here's our call to action for enhanced federal infrastructure and support for caregivers. So we want to recognize and include as valuable members of the healthcare and research team. Caregivers are essential. We want paid and family medical leave. We want to provide workers with up to 12 weeks of partial income so that they can take the time off to be a caregiver. We'd like tax credits. What about providing refundable tax credits for qualified families to defray those costs of caring for a loved one? And then what about Social Security credits? It's not on this slide, but adding that to a person's career earnings when they've taken the time to be a caregiver. We think that these can be some next steps in a call to action. Next slide, please. And finally, to provide my last bit of perspective in terms of how Alzheimer's disease is impacting women in particular, but how it just impacts so many. This quote is from former First Lady Rosalynn Carter. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. Next slide, please. Thank you so much, and I look forward to your questions.
Thank you so much, Dr. Cothran. That was chock full of so much important information. And I know we'll get to this in the Q&A, but I really appreciate the emphasis around isolation as one of the experiences that caregivers often face. I know that was true for our family, and I've seen it over and over again. And there seems to be new data emerging that, especially out of COVID, that isolation can be a risk factor as well for cognitive decline. So I think it's just an interesting, newer kind of data point to dig into a little bit. And I'm also really grateful. I know our organizations have worked together around paid leave. The economic impact of this disease on women, especially in their role as caregivers, is so profound. And you said it so well that, women are basically holding up this unpaid workforce. And if we all went away, who's to say what would happen? So we certainly stand with you and agree that these are really important policies to put forward and to advocate for, and to advocate for together, because certainly we're stronger when the patient advocacy community comes together. So thank you so much for your remarks. I think it's a perfect segue to Niles Godis, my colleague at Us Against Alzheimer's, and our head of government affairs, who's going to share with us, Niles, where we are focused at Us Against Alzheimer's. There's been a lot of overlap in the discussion today, but our policy priorities, and really what other folks listening who are on the Hill or part of advocacy organizations, how we can kind of work together to bringing about some of the change that's needed in this movement. So Niles, welcome, and over to you. And Niles, you're on mute.
Okay, there. How's that?
Great. No
Okay.
worries. It was going to happen to one of us. So
That's right. Well, thank you for the introduction, Brooks, and thanks everyone for letting me be here with you today. So Alzheimer's disease and related dementias are, as we've heard, truly a national emergency. And it is an emergency that disproportionately affects women. I'd like to just touch on a few policy goals we pursue at Us Against Alzheimer's that are important in our fight to end this disease. And these things are important to everyone, and particularly women who bear the brunt of this disease, both as patients and as caregivers. Next slide. First, increased funding for Alzheimer's disease research and additional programs. It is really remarkable, given the enormity of this disease, that just 10 years ago, our nation was spending less than $450 million on Alzheimer's research at the National Institutes on Health. But thanks to the hard work of so many in the Alzheimer's community, including Us Against Alzheimer's, there has been a substantial increase in research funding. The fiscal year 2023 appropriations process is underway, but it looks, we won't know this for a number of months, but it looks as though the NIH might receive as much as $3.7 billion next year for Alzheimer's disease research. That is great news. From $450 million not that long ago to a likely $3.7 billion next year. It is great that Congress is devoting such resources to fighting this disease. And we need to do more to find treatments and a cure that works for everyone. So we know that women are disproportionately impacted by Alzheimer's disease, and the same is true for people of color. So if we are truly to make progress against this disease, we need to do more for women, and in particular, African American and Latina women. If we are not researching how women, in proportion to the prevalence of the disease, respond to new treatments, how can we ensure that women have access to the best treatments for them? We focus on this because when research doesn't adequately include women, our entire nation loses. We all lose. As stated by one author from the Rand Corporation, research that leaves women behind leaves an unknown amount of science unexplored. We literally don't know what we're missing. Now, the NIH does groundbreaking work, and they are a great partner in this fight. Their research will be key to finding treatments and a cure. And we think the NIH can be even more effective with additional resources. So we will continue asking Congress to give the NIH what it needs. Now, in addition to the NIH, we also ask Congress to fund other Alzheimer's-related programs, including at the CDC, federally qualified healthcare centers, et cetera. So next, I'd like to talk about Alzheimer's prevention and risk deduction. If we can go to that slide. There we go. So this is a key pillar in our nation's fight against this disease, because the only thing better than a cure for Alzheimer's is preventing people from getting it in the first place. Us Against Alzheimer's brought together a group of more than 200 partners who work together to make Alzheimer's risk reduction a national priority. That effort bore fruit in December when HHS Secretary Becerra officially added risk reduction as a sixth goal of our national plan to fight Alzheimer's. Now, this means our country will now focus on raising public awareness that there are simple, everyday things that we can do to reduce the risk of developing Alzheimer's. And we heard about a number of these earlier. And we've heard that according to an Us Against Alzheimer's survey, fewer than half of women said they are aware of the measures they can take to protect their brain health. That means that women who, as Brooks put it, so often serve as the chief medical officers for their families may not be fully aware that they could substantially lower the risk of developing dementia. So here's what we mean by risk reduction. Studies tell us that about 40% of dementia cases may be delayed, or in some cases, maybe even prevented by paying close attention to the modifiable risk factors we've heard about. So some of these things are fairly intuitive and pretty well known, things like hypertension, blood sugar, lack of physical activity, etc. And there are some that might not be as intuitive, things like hearing loss and sleep disorders. Now, regarding risk reduction, the Advisory Council on Alzheimer's Research noted that a 15% reduction per decade in the prevalence of these risk factors could result in 1.2 million fewer people with Alzheimer's in 2050. But unfortunately, most people are not getting all of the information they need. For example, only 14% of people surveyed say their healthcare provider has talked with them about how to eat well for brain health. And according to a 2018 survey, 70% of caregivers wanted more information on prevention of Alzheimer's disease. So we were instrumental in making Alzheimer's risk reduction a federal priority. And now that it is officially part of our national plan, we will be working with Congress and the administration to make sure it lives up to its full potential. Next slide, please. So now I'd like to touch on early detection, because we are committed to increasing early detection and diagnosis of this disease. When we look at our own data, close to 80% of the people engaged in our programs are women. And so we work hard to educate them and policymakers about the importance of early detection. Finding out just as soon as possible that someone has Alzheimer's gives people living with the disease more time to be referred for further testing, to learn about community-based services, to make decisions about their future and about their care plan, and maybe even join a clinical trial. So one way of making sure more people are screened for Alzheimer's is through Medicare, specifically the Medicare annual wellness visit. Now, one component of this annual Medicare visit is the detection of cognitive impairment. That's something that is supposed to be done during that visit. The issue is that the Centers for Medicare and Medicaid Services, CMS, which is the agency that regulates Medicare, CMS has defined detection of cognitive impairment as an assessment of an individual's cognitive function by direct observation, with consideration of information obtained by the patient and by family members. This subjective measure falls far short of what older adults need. Approximately 50% of patients with dementia are unrecognized in the primary care setting. But there is an alternative to using direct observation, and that is evidence-based screening tools or tests that are specifically designed to detect cognitive impairment and signs of dementia at the early stages. Now, several of these screening tools are listed on the National Institute on Aging's website. We think that CMS should require the use of one of these screening tools rather than direct observation during this Medicare visit. Now, we have worked with leading Alzheimer's advocates in Congress to have a bill introduced that would improve the Medicare annual wellness visit. The bill is called the Change Act. It is bipartisan, it's bicameral, and we're going to keep pushing for it until it passes. And next slide, please. And so we know that Alzheimer's disease is devastating to women and to communities of color. And we know how important research, prevention, and early detection are. That is why we are so committed to promoting health equity. At Us Against Alzheimer's, health equity is not something that we just bolt on to the end of our work, but rather it is integrated across all of our programs. We support a broad range of policies and programs to promote brain health in high-risk communities. For example, in addition to what I've discussed so far on risk reduction and cognitive assessments, we champion paid leave, paid family and medical leave, which we just heard about as well. This is a policy that would really help family caregivers, the majority of whom are women, and especially women of color. Women are more likely to face the challenges of both caregiving and working outside the home at the same time. In the United States, more than 26 million workers lack access to paid sick days, 26 million workers, including nearly 70% of the lowest wage workers. and only 23% of the civilian workforce has access to paid medical leave through their employer. Caregivers are just juggling so much on a day-to-day basis. And then you consider things like taking a loved one to a doctor's appointment or checking in on them in a long-term care community. And it is clear why we need paid family and medical leave. And all of this is true even during the normal times, if we can call it that. And then something like COVID comes along and it only worsens caregiver challenges. An estimated 8.8 million people missed work due to COVID-19 illness or caregiving. And that statistic is several months old, and so it's obviously more by now. And 6 in 10 reported losing household income. 1 in 5 households sometimes or often did not have enough to eat. So we will keep fighting for paid family and medical leave. Family caregivers need it. People living with Alzheimer's disease need it. And so I'll wrap up today back where I started. Alzheimer's is a terrible disease, and it does not impact everyone equally. We need to keep fighting. We need to keep working. We can't rest until we end Alzheimer's disease. And in the meantime, we need to keep doing everything we can for the people who are living with it. Thanks very much.
Great. Thank you so much, Niles. Really appreciate you walking everyone through those 4 policy priorities for Us Against Alzheimer's. Certainly, they are shared among many of our fellow patient advocacy groups. And, we're going to continue, as you said so well, fighting the good fight. It's a complex issue and lots of moving pieces and roadblocks for families. And the more we can do together to overcome them, the better. I'd like to now open it up to questions and invite all of the panelists to go ahead and turn on their video. And then when there's certain questions directed to you, you can go ahead and unmute. We have a couple questions, Dr. Goldstein, for you. And I know you answered one of them in the actual Q&A, but just for the benefit of the recording and for others that might not be seeing the Q&A, there was a question around, is there an increased incidence of Alzheimer's disease in women who experienced premature menopause? And is there a link to the number of pregnancies and the age of onset as well? So would love for you to just share verbally your answer. So for those watching the recording, they can also benefit from your brilliance.
Okay, thank you. Actually, that's a great question. And there's a lot of work being currently done now, looking at premature menopause, looking at premature menopause, both naturally and also surgically. There's a lot to come, I would say, in the next 5 years to actually, sort of be more definitive. But the bulk of the evidence right now shows for those women who can medically be on hormone replacement, that hormone replacement actually has beneficial effects for maintaining cognitive health if you have premature menopause. And what's still being looked at is the route of administration, oral transdermal. Transdermal will not go, oral goes through the liver, so transdermal does not, so it tends to have less side effects. The dose and the duration of taking that, those questions are still really, the jury is still out on those. We need more work in this area. It's extremely important. I do want to say, of course, every woman eventually goes through menopause. There are different ages of menopause. There's really the average age now is 51. It can be anywhere from your mid-40s to up to 63 years of age. There is some evidence that later age of menopause actually has beneficial effects, and that's been tied to a longer exposure of the brain to natural estradiol. And so again, it's really supporting evidence about the importance of hormones and its impact on the brain. But it's not all about hormones. I don't want to say that. And by the way, I don't want to be negative about menopause. Of course, everyone goes through menopause, and how the brain and our body can maintain what we call estrogenicity in the brain. There are other sources of estrogenicity aside from the ovaries. And so women who have maintained brain health and cognitive health, we're really interested in doing studies on what are those factors. And we have people are interested. I'm happy for them to contact us. We're doing some work in this area and have shown that some of these other sources and other groups are looking at this, provide that what we say estrogenicity for the brain. Just like with the loss of glucose metabolism, there are people really working on what are the new fuels that the brain uses in order to maintain and maintain brain metabolism at a rate that keeps our neurons alive. So a lot of work being done in this area, but it's very critical. Thank you for the question.
Yeah, no, it's a fantastic answer. Staying with you for a moment, I'd love for you to dig in a little bit more and talk about the causal pathway as it relates to vascular, and specifically you highlighted stress. And I would love if you could expand on what you're learning and what the science is telling us is the impact of stress on women. We've been, there's been an interesting narrative, I think, and I've heard it a lot around the caregiving conversation, that women are managing so much in their minds, right? As if you're parenting, you're constantly thinking about all of those duties. If you're caregiving for aging parents, you're thinking about that, you're doing your work, and it's a really profound amount of stress. And would love to kind of hear what you're learning and around the latest science, and just to shed a little more light on that particular risk factor, which may not be as obvious to folks listening in, and in particular, the sex differences for women.
Mm-hmm. Well, how much time do you have? Because this is
well, I'm a little stressed because we don't have that much time.
I will be brief, but if people really are interested in this, I'm happy to provide more details. We've been studying this for the last 25 years, and we look at how the circuitry that regulates stress is as the memory circuitry and stress circuitry, emotion, which is the same sort of circuitry that regulates our emotions. Those are the most, as we say, highly sexually dimorphic brain regions in the brain. They regulate, they develop differently in the male and female brain, and they function differently across our lifespan. And so how we regulate that, these regions not only show sex differences, but as I told you, they regulate our gonadal hormone release. They specifically, the stress response regulates our gonadal hormone release. It also regulates our adrenal or stress hormone release. So there's shared brain regions there. And those brain regions, as I told you, are shared with memory circuitry. So that's why we think stress, mood, memory, they all really come together and impact each other. And finally, those stress circuitry regulates our immune system, and these things, and as I told you, also regulates our autonomic function. So it has major effects on both the brain and the body, and which is one of the reasons why probably stress is associated with every chronic disease we know. And this is true for men and women. Of course, men also are under a lot of stress these days as well. So it's not just a female issue, but we regulate it differently. We've shown that we actually regulate the stress response differently across the menstrual cycle. And we actually change that regulation with age. And we do so in a sex-selective way, a sex-dependent way. So those are some of the little key points I'll throw out there, but I'm happy to go into details for people that are interested in this or send them articles.
Great. Thank you so much. And we've had actually several questions related to the availability of clinical trials. And we've had a couple participants actually post information about trials happening at NIH. So we can certainly summarize that in our follow-up with folks. But are there particular trials that women can enter regarding AD? And a follow-up question on that, which I think is such a great one, and one that we are working on every day too, is how do you discuss this with your internist? If you feel like you want to be part of a clinical trial, do you have any recommendations on how to raise the topic?
Well, people are their own best advocates. I would just ask the question. and you will find that your physician will have an answer one way or the other. And if he or she does not, they will find the answer for you. And so it's really important to advocate for yourself. We talk about this not only with Alzheimer's disease, but with cardiovascular disease, which our treatments were essentially built on male models and male animals, and that's not true anymore. And this is true for a number of different diseases. It's important to talk to your physician about whether there are some specific things that as a man, as a woman, or as a male or female, that you can enter into, whether it's a trial, and we're talking about the aging effects, or whether it's really about maintaining your vascular health, your metabolic health, and your brain health in general.
Yeah, I agree. And I know someone just posted the Alzheimer's Association has a trial match program at alz.org. We know there's clinicaltrials.gov. There's many different places online where you can also search and find if you need to kind of get some more information that you can be armed with when you go and speak with your provider or community based clinic. Along those lines, Niles, another question for you. Any advice on how do you get tested with Medicare? Which is really the crux of the matter, isn't it? I mean, it's often, as you said so well, people can use observation. So I think providers can use observation, and that is enough. So I think it really does, unfortunately, fall on the person advocating for himself or herself or for their loved one. Do you have any thoughts on that?
Yeah, you're right. And I think in many cases, what you said is absolutely true, Brooks. And it goes back to what Dr. Goldstein said about people needing to be sort of their own advocate. Every Medicare beneficiary is entitled to an appointment once a year called the annual wellness visit. It is not just sort of a head to toe physical. It is focused on the management and prevention of chronic diseases. And so everyone who is a Medicare beneficiary is entitled to that appointment once a year now. And what's important is that if someone is concerned about their cognitive health, what's important is to simply ask the doctor if they would use a cognitive impairment test during that annual wellness visit. There are at least 4 of them, maybe even 5, listed on the NIA, National Institute on Aging website. At least one of them says that it takes less than 5 minutes to deliver. And so it is free, it is covered by Medicare, and folks just have to ask their doctors about it.
Great. And I would just add, I know I'm moderating, but I will add that at Us Against Alzheimer's, we have a resource called My Brain Guide. You can visit mybrainguide.org and take a memory questionnaire for yourself or a loved one. And then we provide a summary that you can bring to your doctor, as well as an explanation of how you did. And we have found that people feel more empowered when they have something physical in their hands that they can bring to have those discussions. Our medical experts that helped us create Brain Guide, Dr. Goldstein among them, also, really reinforced that when patients come with something specific, as opposed to 100 pages of printouts of off Google, it's a little bit easier for the patient provider interaction. So just offer that to folks as well. Dr. Cothran, I'd love for you to respond to a question, which I feel like we've all been in this space trying to answer for so long. I'm an adult daughter. I'm going to help my mom no matter what. I don't necessarily see myself as a caregiver. How is the Alliance kind of navigating that in today's, well, I guess we're still in COVID, but, to really reach those people that, as you described, are dealing with double jeopardy. They don't necessarily identify as caregivers, but we know they need our support. And then friends and family that are watching, that caregiver going through that experience. How are you all working in the community and reaching folks in light of that, in light of people just thinking they're just helping their loved ones?
Yeah, I think that's a great question. So I'm relatively new to NAC, but as we're planning future work, we are trying that we're partnering with a variety of multiple partners in the community setting. We really want to make sure that we are finding different ways to reach people. So unfortunately, not everybody has internet and not everybody knows about NIA or, the Alzheimer's Association. It's like, we know about it, but not everybody else knows about it. Not everybody is reading these journal articles. So it's like, what can we do to actually broaden that reach? And so certainly word of mouth and trying to make sure that we're getting out more. So that's certainly one thing, but it's, in the process, but it's very important because we really are about equity as well. It's very much integrated in what we do. And that is one way to make sure that we do that, is that we're not just trying to reach the folks that, know about the studies or know about, the National Alliance for Caregiving, but really making sure that what can we do to put ourselves out there more. So that's one thing. And then I did want to just quickly add that for those that don't know that are attending today, the Alzheimer's disease research centers across the country also may be a source of what clinical trials might be going on. And so that's something to take a look at too, just as an aside. So back to us. So we are definitely looking at caregivers, but really trying to make sure that we're doing, being more intentional in our community engagement practices and partnering with organizations that really have their boots on the ground to make sure that we're reaching those folks and not just trying to do, again, those typical outlets that not everybody has access to.
Yeah, that's a really fantastic point, and it's a perfect segue, I think, to another question that came through around Black and African American women seems to be the group that is most at risk for AD. What outreach and community engagement strategies have you found to work well? And I can speak. I'll share just one piece of example that we have at Us Against Alzheimer's that might be of interest to folks. Because when we launched mybrainguide.org, which is our really first consumer-facing platform, we've reached over 600,000 people, but our outreach was very much done nationally, and the utilization was primarily among white women between the ages of 60 and 85. And we wanted to reach more women of color. And so we started a program in Atlanta, Georgia, which was identified as a particular location where there's a higher prevalence of Alzheimer's disease among minority populations. And to your very good point, I mean, we didn't just go into Atlanta and start, talking about Alzheimer's disease and Brain Guide, but instead we partnered with community-based organizations that are embedded in the community today. We gave them train the trainer materials. We invited their feedback. We modified our resource based on their feedback because there were places where it wasn't hitting the mark. We've given them materials. We've made contributions to their community-based organizations, and they are champions now of this brain health work and bringing that message forward. And we've increased by 96% the utilization. I should say we have to start to, I think, with a lower, a lower ask. I think going into communities and expecting people to sign up for clinical trials is a really big ask. And it's a big thing for people to do. But going in and saying, would you like to come to this webinar to hear more about brain health? Or would you like to learn about healthy nutrition or moving your body for your brain? Those are easier things to say yes to at first. So from a public health perspective, I think we have to be thoughtful about that as well. But I think we are at time. I was looking at the clock and then all of a sudden I lost that last minute. So I just really want to thank everyone for the participation today. Thanks to the Society for Women's Health Research, National Alliance for Caregiving, Dr. Goldstein, Dr. Catherine, and Niles for participating today. You all, I feel like we could have been on this call for much more than an hour and 15 minutes. You have so much information and expertise to share. So maybe we need to take this on the road and do another one and dig deeper into these issues. But thank you for your participation. We will be sharing a recording back out with participants and are just grateful for the opportunity to shed light on women and Alzheimer's disease and talk about ways that we can make change. So thank you so much for being with us this afternoon.
Thank you for having us.